Hello, my name is Meg Kwong, the Executive Director at the Center for Connected Health Policy, the federally designated National Telehealth Policy Resource Center. Today, I want to talk to you about using telephone to provide services during COVID-19. A few disclaimers today. First off, any information that I provide today is strictly for informational purposes. It is not to be considered legal advice. CCHP always recommends that you seek out legal counsel if you are looking for a formal legal opinion. And also, if I happen to mention a company or show some sort of product, please know that neither I nor CCHP has any type of relationship or financial arrangement with such a company. So the Center for Connected Health Policy was established in 2009 as a California telehealth policy organization. We're a program underneath the Public Health Institute. In 2012, an opportunity to become the federally designated National Telehealth Policy Resource Center became available. We applied for the grant. It's a grant through HRSA, and we won that and we have been serving in that capacity ever since. We also work with a variety of other funders and partners on more specific projects related to telehealth or connected health, and there you see a couple of the partners that we work with. Some of the projects that we do at CCHP, we do track all of the state Medicaid policies, laws, and regulations related to telehealth. We do a report twice a year, once in the spring and once in the fall. Right now, we are working on the spring 2020 update. The information included in that report will not include the COVID-19 temporary changes, but it will include all changes up through February of 2020, and that should be out in a few weeks. We also act as the administrator for the National Consortium of Telehealth Resource Centers, which I'll go into in a moment. And we also convene a coalition of over 70 statewide groups in California who are interested in telehealth policy. The National Consortium of Telehealth Resource Centers are made up of the 14 telehealth resource centers who all receive funding from HRSA underneath the same grant program. There are 12 regional resource centers that cover specific states, and there are 2 national resource centers, one on policy, which is CCHP, and one on technology. And we all work very collaboratively together underneath this umbrella of the National Consortium. That's to make sure that we are utilizing our resources effectively and efficiently, and also to cut down on any type of duplication of work. I also like to say that, I encourage folks to reach out to the Regional Resource Center covering their state, but really if you reach out to one of us, you're getting all 14 of us because we are in constant communication with each other and we do work closely with each other. CCHP, as I mentioned, does track all of the state Medicaid policies and laws and regulations related to telehealth. I mentioned the report just a few moments ago. That is a report that you can download as a PDF. It's about 450 pages, but we also put the information on our website through an interactive map, which if you're just interested in a particular state, you can just click on that state and it'll bring up the information. You don't have to download that rather bulky report. So today I wanted to talk to you about telephone and COVID-19 and what is being reimbursed for that, because I think there's been a little bit of confusion regarding some of the policies on phone and telehealth and what exactly is covered when you provide a service via telephone. So to start with, we're going to talk about both federal and state policy and how that is being treated. So underneath Medicare, for telehealth, what Medicare has said, at least in their interim final rule dated March 30th, they have said that they are going to count for telehealth the type of technology that's used in order to provide services via telehealth in Medicare to get reimbursed by Medicare. It needs to be live video. It's a two-way, real-time, interactive communication between the patient and the distant site physician or practitioner. So because it needs to be a real-time interactive two-way communication that includes audio and video equipment, so that's the important thing right there. It says video equipment. That does eliminate audio-only phone. Now, that does not eliminate your smartphone because your smartphone does have a video capability, but what they are saying is that it cannot just be an audio-only phone way to count as a service delivered through telehealth and be reimbursed by Medicare. What Medicare does have, though, for phone are specific codes that they said can be delivered through audio-only technologies, through the telephone. And your first set are the virtual check-in codes, and I think a lot of folks are very familiar with this. These are those quick check-in codes that, don't aren't a result of a visit from 7 days before and don't result in a visit immediately afterwards. They're considered to be very brief, literally check-in calls, 5 or 10 minutes. They do not pay a lot, so they pay about $10 to $15 around there, but you can do them over phone. There's also a set of services that they have also said that you can use phone for, and those are for CPT codes 98966 through 98968 and 99441 to 99443. So again, those are a set of codes that you can use to provide services via phone as well. And then there are interprofessional telephone internet EHR consultations, or e-consult. This is a provider to provider consultation that you can do that is also eligible to be done over phone and get reimbursed for. Now, Medicare will cover these services, but keep in mind, they have not called them telehealth services. They've called them communication-based technologies. And I think in some of the discussions that have been going on with all these rapid policy changes, people have been lumping the two things together, saying like, yes, telephone can be done by phone. And what Medicare is saying is like, services can be done by phone, but they're called communication-based technologies. They are not those telehealth technologies. Now, I will caution, as of recording this particular video, April 22nd, 2020, that is the policy now. But as we've seen, policy can change rapidly. So Medicare or Congress could decide that we're going to expand the definition of like the type of modality that you can use when providing services via telehealth underneath the Medicare program, and it can include a lot more things, including audio-only phone. But as of now, April 22nd, 2020, this is how the policy stands. Telehealth does not include audio only underneath the Medicare program, but what Medicare does have is a grouping of services that they say you can use audio only delivery in order to get reimbursed for these particular services. Another way in that phone is being used is what the DEA has been doing. And again, this is a very specific, narrow exception here. And it's that second exception. So the DEA, because we are in this public health emergency, has loosened up a few restrictions on how you prescribe a controlled substance using telehealth, but without having to have that in-person examination. And one area they haven't done it for all controlled substances, but one area where they will allow it to be loosened up a little bit, it is when you are treating an opioid use disorder and you're prescribing specifically buprenorphine. That can be done over the phone as well if these conditions are met. So again, that's a very specific type of situation in which phone can be used. So what are states doing? So this is sort of the landscape pre-COVID-19 of what states were doing in their Medicaid programs. Live video was like kind of the most popular thing to be reimbursed for. Store and forward remote patient monitoring, not as popular. Pre-COVID-19, and still, because this has not changed, on state statutes, Medicaid policies, regulations, a lot of states actually specifically excluded telephone from the definition of telehealth and telemedicine. So that's why in a lot of emergency waivers, you'll see them say, we're expanding telehealth and telephone delivered services. They had to call out telephone specifically because on a lot of state laws or in their Medicaid policies, they've explicitly included, they had language that says telehealth does not include telephone. So that is why they had to specifically call it out in their waivers. So what are they doing now? So they are, like Medicare, allowing some expansion. You'll see that. I just mentioned a moment ago that you'll see an executive order saying that we're going to allow more phone to be used. Keep in mind, though, check to see what exactly they mean by that, because they may only be allowing some of those services that Medicare calls non-telehealth services, those communication-based services, as the type of services that they will cover and reimburse for when they're talking about phone. So it may just be that they are saying like, we'll cover services provided by phone, but the only codes you can charge if you do that are the G2010 codes or the G20112 codes. So that may be why some providers are thinking like, well, I provided a service and I billed a code or I billed for it, but I only received $10. You're probably billing the G codes, which is the only amount that will pay for. It's like that very small amount of $10 or so. So check the policy of like what exactly they're saying when they mean will reimburse for phone delivered services. Is it that just that virtual check-in codes, or do they mean something more expansive? So here's an example of that. So in California, the Medicaid policies, they have said that they will cover the G2010 and 20112 codes. Those are those quick virtual check-in codes, pays about $10 to $15 or something. But what Medicaid in California has also said is that if you meet certain requirements and you do it over phone, we'll pay you the usual amount that you would have for that service. But if you don't meet those certain requirements, then you got to bill it with the G2010, 2012, and we'll pay you that lesser amount, that $10 essentially. So they do in California Medicaid allow for more expansive coverage for a service delivered via phone, but if you don't meet those certain requirements, they are saying that then you got to bill it for like the virtual check-in codes, which pay less. Compare that to Florida, where they said like the specific codes they'll reimburse for if it's done by phone is 99441 to 99443. So you've got to check the state policies to say, well, what exactly do they mean by that when they say that they will cover by phone? Is it like just the virtual check-in codes? Is it something more expansive, or is it 99441 to 99443 codes? Same thing goes for a private payer. So if you are dealing with private insurance, they may only be reimbursing for the G2010, G20112 codes. So check with them when they say like, yes, we'll cover your services if you do it by phone. It's like, well, what do you mean by that? And if they tell you like you would bill with G2010, G20112, it's the virtual check-in codes. You're probably only going to get a very low amount for it. But if they say something like, just bill it like you typically would and just put like a typical modifier like GT or something like that that's used for telehealth, then they're likely basically having a more expansive policy like the California Medicaid program. So one other thing to keep in mind, a lot of these are emergency orders and some of them have actual expiration dates on them. A lot of them say like until the public health emergency is declared over, but other emergency orders, some of them did have a specific date, such as like ends April 15th, ends May 1st. So some of these are up for expiration or have expired, and some of the ones that have expired, they've extended them. So keep that in mind as well, that this is coming up for some of these emergency orders. And these are just some resources that you can access at our CCHP's website, a newsletter that you can subscribe to, and we do send out alerts of like any breaking information, and then once a week on a specific topic as well. So I hope you have found this video useful and that it has cleared up some confusion for some folks. So thank you very much, and I hope you have a great day. Stay safe, everyone.